Welcome again, my colleagues. This is the second nuclear isotopic scan Viva seat cases. Our first candidate, this is a 30-year-old male patient um, complaining of a neck mass. Go on. Sorry.
Okay, sir, I am presented with 30 years old patient, which is presented with a neck mass.
Sorry. Consider because there are no any history. He has a neck abnormality.
Okay.
Yes.
These are the grayscale ultrasound images through the neck, which are taken at the level of the thyroid gland. I can appreciate the left lobe of thyroid gland is normal.
Yes.
Sir, on the right side, well-defined echogenic hypoechoic lesion seen, which does not contain any internal calcification. It has well-defined margins and
Doctor,
no surrounding.
do you do you think this is the normal thyroid that usually
The
we
size is smaller.
yes? Hmm?
The echogenicity is normal, but size is smaller. Is
Side
any history of neck surgery?
no?
Sir, on left side, echogenicity of lobe is normal, but the size is smaller.
Yes. What is your differential or what's your concern?
It can be autoimmune thyroiditis.
Okay, what else?
If patient has no history of surgery, then any infection which is leads to atrophy of the gland.
Okay. What do you want to do next?
I will advise nuclear technetium 99M study for the further evaluation.
Okay. What do you think? Hello?
This
Hello?
is a technetium 90. This is a technetium 99M. Hello,
Yes, go on.
hello.
Yes. I hear you.
This is a technetium 99. This is a technetium 99M nuclear study in
Yes.
which I can't appreciate any normal uptake in the region of the thyroid gland.
See,
But there
technetium,
is
doctor, technetium bear technitate. This is very important. Okay, because technetium is the phase, and the bear technite is or the tracer, and this is the specific part of the radioactive isotope, and the bear technitate is dedicated for thyroid. Go on. Hello. Hello.
Yes, Dr. Rami, we can hear you.
Sorry, many technical problem today. No problem. No problem. Our candidate, can you start again? Hello. Hello. Dr. Nagam, next candidate, please.
Okay, please, candidate 3, proceed.
I'm candidate
Uh,
3.
Okay.
yes,
Sir, I
I'm
think this
candidate
candidate
2.
2 as well.
Candidate 2, regain online again.
I'm candidate 2.
Okay,
Yes, I'm candidate 2.
candidate 2. Okay. Uh, let's complete this case. Doctor, our last candidate find that the thyroid is very small, and then she asked for isotopic scan, technetium technitate or technitate anyway. Technitate is better. And this is the static image. Tell us what happened here.
So this is a static image of technetium 99M per technitate showing no significant uptake at the level of both thyroid glands.
Okay.
Uh,
What is this? See, doctor, to help you, this is SSN, suprasternal notch marker. Okay. So this is the region of thyroid. There are uptake here. Consider, يعني, this is the mandibular region overall. Tell me what happened.
so could be ectopic thyroid gland is seen at the level of thyroglosal duct system from the base of the tongue to the
And so your final diagnosis is
ectopic active thyroid tissue at the
at
level of the above the hyoid level.
excellent. By the way, my colleague, there must be another marker here. I think the chain marker. But anyway, I helped my colleague, and he pick up the diagnosis. This is the XF. This is the expected region of the mandible, and there are uptake. So this is means this is ectopic thyroid tissue. Where is this? This is in the region of the mandible overall. So it is almost at the back of the base of the tongue. So the diagnosis is ectopic thyroid. Thank you, doctor, so much. Doctor, could you
Yes,
tell me uh, why the ectopic thyroid is here in the base of the tongue? Why?
because this is the level of the thyroglosal duct cyst. Can be
Tell
anywhere
us,
in the
tell us in the embryological pathway of the thyroid development. Could you know it?
um,
From where the thyroid can start.
start of the base of the tongue at the level of along the thyroglosal duct cyst.
Okay. It is started from the base of the tongue. Okay. And then it is descend
Midline.
step by step till it is became in the normal lower neck position. Arresting of this process result in ectopic thyroid. Okay. Suppose the thyroid go down in its normal position. During the development process, there are a track or a tube here, okay, between the base of the tongue, then midline, hyoid, then down. Along this track, you can find any abnormalities. Tell us some abnormalities.
Thyroglosal duct cyst, thyroglosal duct sinus
Excellent.
or vestibulus.
Excellent, doctor. Thank you so much. It was ectopic lingual thyroid. Next candidate.
Yes, sir. I'm candidate number 3.
Okay. Doctor, this is a 40-year-old female patient with right hip pain and low back pain. Go on.
Okay, sir. I'm provided with the radiograph of a patient who presented with right hip pain and lower back pain. The first obvious abnormality I could appreciate is significant diffuse osteopenia noted along the right hip joint. And there are significant degenerative changes with superior and central migration of the right femoral head. Significant degenerative changes involving the pubic symphysis
One
and
second.
multiple lytic
One
in
second.
the
1 second. What's the name of this deformity?
uh, coxa magna, acetabular coxa magna.
Hmm?
Sir, I think coxa magna.
Not coxa magna. Something else.
I'm not. There is acetabular protrusion and there is coxa something. I don't remember
Not
exactly.
coxa.
حياكم الله سمعنا الكرام.
Protrusio acetabular.
Acetabular. Okay,
Why?
sir.
What is the difference between the two entities?
Sir, in the protuso acetabuli, the femoral head is migrated medial to the medial to the brim, and in the coxa magna there is just the protrusion of the acetabulum, but not the femoral head.
Okay, so uh, see, I will tell you what I know because I confused. See, my colleague, this is a protrusio acetabuli. Why? Because the acetabulum and the femoral head, see this line? This line, this line from here, the ischium, this ilium. So ilioischial line, this is straight line. Okay, this one. Okay, I'm speaking about the straight one. The curved one is another entity, iliopectineal. I'm talking about ilioischial. When the femoral head and the acetabulum go medial to this line, this is protrusia acetabulum. Okay, look here, both of them are medial. But when only the acetabulum is medium or one entity, this is not protrusio acetabuli. Doctor, what's your diagnosis here?
The rheumatoid.
What else?
Sir, any
This is
rheumatoid?
a 40-year-old female patient. This bone density is acceptable for you?
No, sir. It's significantly osteopenic and decreased bone density.
Okay.
And there are multiple cystic lucencies.
Okay. So, what's your diagnosis?
Sir, maybe I'm thinking of some arthritis.
What else?
Maybe some superimposed infection. I'm not sure because there is diffuse osteopenia and central migration.
What else? We are in nuclear session.
There transient synovitis, but there is no central migration in that. And
Doctor, this is a chronic disease, chronic hormonal disease. What do you think?
chronic hormonal disease.
See,
Okay.
there are osteopenia, there
Yes,
are protrusia acetabuli, and you told me
yes, sir.
there are some cystic changes which may considered as brown tumor. So,
Okay,
what?
hyperparathyroidism.
Yes, what will you do next?
And I would like to see, I would like to do a scan for any parathyroidadenoma, any technetium scan, or a maybe scan I would do
Okay.
to look for parathyroidadenoma. I could do ultrasound to see parathyroid. I would like to see if it's primary hyperparathyroidism, secondary or tertiary.
يلا, tell us what happened here.
Sir, I'm provided with frontal images of the MIBI scan. So is it the MIBI scan? And I could see an intense focus tracer uptake along the lower pole of right lobe of thyroid gland,
Yes.
concerning for parathyroid adenoma.
Okay. But this STEMIB scan can be uptaken by the thyroid. How
Yes, sir.
to
We have to do
confirm?
the delayed imaging, and the thyroid will show the washout, but the parathyroid will retain the contrast.
Could you tell me what will you do next to confirm your diagnosis, at least anatomically?
Sir, I would like to do an MRI or
No, no,
or
no.
a
In
PET
nuclear
CT.
medicine. No, in
PET,
nuclear medicine.
sir, PET CT.
Expect,
Okay, sir.
expect.
Yeah, this is
What
in the
is,
region of parathyroid.
yeah, what is the value of expect? Anatomical?
Sir, anatomical location of the lesions.
Anatomical location. Okay. So give me your differential diagnosis.
So considering the imaging appearances, I am thinking of parathyroid adenoma as my first differential,
What is
causing
the most
hyperparathyroidism.
what is the most common cause of parathyroid adenoma in your list?
Sorry, sir, in
What is the most common cause in of يعني parathyroid adenoma?
most common cause of parathyroid adenoma. Sir, it may be secondary parathyroid adenoma due to renal failure or something.
Yes, renal failure. So
Yeah.
patient must evaluated for a renal function. Okay.
Okay, sir.
Okay, let's repop this case again. See, the patient here has diffuse osteopenia. It is very adult, 40-year-old. And what happened here? unacceptable in this age. Unacceptable deformity. And the other side is, it looks like normal. What happened here? Medial migration of the medial acetabulum wall and the femoral head medially to the line here. This line, this line, this is the ischium, this is the ilium. So ilioischial, ilioischial. This line is IB, iliopectineal. Okay, this is not coxa magna. Coxa magna means enlargement of the head. Enlargement of the head. Different entity, but confusing us a little bit. This is a systemibi or maybe scan. Maybe scan can be uptaked by both thyroid and parathyroid gland. The delayed image is the differential point because parathyroid adenoma retain the systemibi tracer in the delayed image. This is the cause why we should look for delayed phases, because the parathyroid gland retained in comparison to the thyroid, retained the tracer. Thank you, doctor, so much. By the way, this patient maybe first you will treat renal failure. Some of them may be treated surgically by removal the gland if the renal failure and the supplement is not responding. Especially, see, this case looks like severe. This is very severe. Thank you, doctor, so much. Doctor, can I ask you last question?
Yes, sir.
Give me two causes, abnormality of the bone causing this protrusio acetipuli.
Sir, I remember just the rheumatoid and I think there ankylosing spondylitis.
No, rheumatoid. I don't know, but maybe acceptable. But there are two very common causes, very common. One of them is congenital and very common in children, and one is very common in elder people. And they are a differential diagnosis to each other.
Sir, Paget's.
Budgets, okay. This is for the elder. And what about the children?
Sir, rickets maybe.
No. One differential diagnosis to budget, but in young age, in children.
Sir, I don't know.
Related to the
Maybe
bone formation.
maybe hemophilia.
No. Fibrous
Fibrous dysplasia.
dysplasia. Fibrous
Okay,
dysplasia.
sir.
Thank you so much. Next candidate. Next candidate. Hello?
Yes, candidate 1, if you can rejoin, please.
Any candidate, Dr. Anam, please. Any candidate.
Okay, candidate 4.
Okay, I'm candidate 4.
Okay.
Good
40-year-old
afternoon.
female patient presented with osteopenia and low level calcium. She is 40 years. Yeah.
Okay, so I've been presented with T2 axial images, MR images. So here I can see that there are hyperintense angle in one of the body of the cervical vertebra.
Don't worry about it. Look here.
Okay, so
First time.
okay,
Look here.
okay.
What happened?
So I can see that there is intermediate signal
Okay.
just below the lower lobe of the left lobe of thyroid.
Excellent.
So I'm thinking in terms of parathyroid adenoma.
Yes.
So I will check the clinical history of the patient, as the patient already had hypocalcemia. So it may represent parathyroid adenoma, which is causing hypocalcemia. So I will come with the finding to the referring physician and further confirmation with parathyroid MIBI scan or MEB scan is suggested for confirmation.
What's your
So these are planner, technetium, thyroid, and parathyroid scans. Here I can see that there is.
1 second.
This is simple.
1 second. See, read
Okay.
here. What happened here?
So this was done with simple technetium 99 per technical thyroid scan.
And this is parathyroid.
This is parathyroid scan, which is subtraction scan, which is usually done with
And this is
MIBI or thallium.
Yeah, see,
So
this is the subtraction. What happened here?
yeah,
They remove
So-
this thyroid.
thyroid
How we can
from the
characterize? So 1 second. How can we characterize it? Look here. They cut the thyroid. And what is it?
This left is the parathyroid adenoma left behind.
Okay.
Thyroid activity was subtracted and the parathyroid activity was visible on this scan, which was also seen on late parathyroid scan on above image.
Okay. What's your management?
So I will convey the finding to the referring physician and further evaluation with surgery and surgical consultation is recommended for further management in this case.
Okay. What type could you enumerate types of parathyroid adenoma?
Parathyroid can be at local position or like there are 4 parathyroid glands which may enlarge and produce parathyroid adenomas, or they may be ectopically present in the superior mediastinum, or there may be just parathyroid hyperplasia.
Yes.
If the glands are enlarged, like 4 glands are mildly enlarged, so they may be like parathyroid hyperplasia. We suggest if the 1 or 2 glands are enlarged, which are visible on imaging, so they are called parathyroid.
We have primary type, which is called hyperplasia, and we have secondary.
Yeah, which is secondary due to renal failure.
Okay.
Or
could you
tertiary,
describe?
can be tertiary.
Yeah. Could you describe the technique here, the subtraction technique? Describe.
Okay, so I can see that the first patient is inducted in the supine position with simple per technetium per technetium scan, and patient kept in the same position and then injected with MIBI or thallium, which is available. So the technetium scan was subtracted from this MEB scan because the technetium only goes into the thyroid.
1 second. See, my colleague, she answered very well. What happened? This is technetium pertechnetate, which is absorbed by the thyroid, and then this is a system maybe. Okay, technetium pertechnetate not absorbed by the para, only thyroid, but systemibi can absorb it by both of them. Okay, and then they subtract the systemibi, they subtract this one from the systemibi, give me or give us this one. Somebody will tell us, doctor, this is looks like only parathyroid. Okay, you are correct, because this is delayed, but I'm speaking generally. When you are asked in the exam, tell the examiner, we do this is regular thyroid, this is regular parathyroid exam, whatever the tracer. Okay, then they subtract this one from this one, give us this one. How to differentiate or to characterize the subtraction? Either it will be written here, or look here, there are a white defect here. Thank you, doctor, so much.
Thank you.
Welcome. Next candidate. Next candidate.
Yes, sir. I'm candidate 6. Yes.
Okay.
Okay, sir.
history of the patient, please.
Doctor, this is 10 months female patient presented with 3 history of wheezes and obstructive
Yes, sir.
weight symptoms, especially when
Okay, sir.
lying down in supine. Tell us what happened.
Okay. Okay, sir. I'm provided with chest X-ray frontal projection of a pediatric age group. I can appreciate there is a fairly defined homogeneous density identified in the right upper zone, which is seen, which shows a smooth inferior margin, but however, its superior margins and medial margins are indistinct. I can also appreciate the arch of aorta and hilum through it. So I'm suspecting it's not anterior to the diasternum. Sir, it's also causing mild displacement of the this trachea, but there's no compression, acute compression, and also, sir, it's likely seen to extend beyond clavicle, but not clearly visualized. So I'm suspecting any mediastinal mass which is causing mild compression over the trachea.
Okay. Which mediastinal?
Sir,
Look again. Which
sir,
mediastinal?
sir, because heart shadow is seen through it, and also the aortic arch is also seen through it. So I'm suspecting some posterior mediastinal lesion.
Okay. See, you can see at least
Yes,
this upper part,
yes, sir.
SVC. Okay.
Yes,
So
sir.
this
Yes,
is
yes,
not
yes,
anterior.
sir.
And what about this?
Yes, sir.
Looks like.
Sir, hilum is yes, sir. Hilum is also seen through it.
What
So
about
it's
the
also
rib,
not medial.
the intercostal spaces? What
Yes, there
about?
is also widening of intercostal space as compared to the website.
Okay.
So this most probably a posterior mediastinal mass.
Okay. What will you do next?
Sir, I will do, if baby is still available, then lateral view would be helpful. And then I can,
The lateral view
yes,
confirm your diagnosis. This is a posterior mediastinal mass. Give me some differential diagnosis, please.
okay, sir. In posterior mediastinal, sir, the first differential neurogenic tumors is neurofibroma, schwannoma.
Excellent.
And sir, sometimes a neurogenic cyst also, sorry, bronchogenic cyst also may extend. Sorry, neuroenteric cysts also extend.
Okay. What's your
Also,
next
sir,
step?
sir, next, sir, CT scan or MRI. Sir, MRI spine would be more better because CT scan have radiation. It's harmful to the. Okay, sir.
What do you think?
Okay, sir. So there's a large mass which is seen along the right right paravertebral region, and also, sir, it shows some specks of calcification. I will want to confirm on bone window that these are calcific specks. This is a homogeneous mass lesion, and
Okay.
it's causing significant compression of the right main bronchus.
Yes.
And but underlying bones, oh, yes, sir. This is a large homogeneous mass. Okay, sir. Sir, I also want to check the bone window because I'm suspecting some bone erosions as well.
Don't worry about it. Give me a differential
Okay, sir.
diagnosis. See, like I advised
Okay,
you before, don't
okay.
ask for further sequences or images before you give some differential, some suggestion for the examiner.
Okay, sir.
Mm.
So, considering this, sir, paragangliomas can also be a possibility. Germ cell tumors can also be because it also shows calcification.
Doctor, do you remember the age of patient?
Yes, sir. It's a young patient.
How old exactly?
It's 9 to 10 months, I think.
Okay, and
10 months, yes, yes.
what is this? Describe it.
Sir, okay, sir. So these shows calcifications and
What's your
internal areas
differential
of this.
diagnosis?
So 10 months.
Yes. Posterior
Yes, sir, yes,
mediastinal
yes.
mass. Is this solid or soft? Completely.
Soft.
Okay.
Yes, sir. Sir,
Is there are any clue for fat content or not?
no, sir. No, I don't think so.
Okay.
There is no
Very
fat
excellent.
content
Excellent.
in it.
So is
Yes,
this
sir.
teratoma or not?
Yes, sir, teratoma not because fat is not there.
Okay, so we excluded first possibility of soft tissue mass
Correct.
calcification. What is the other possibility, especially in this age group?
Sir, paraganglioma can be possibility.
Okay, okay.
Posterior.
You mean neurogenic tumor. Okay.
Yes, sir,
What is
neurogenic
the
tumor.
most common neurogenic tumor in this age group with calcification?
Neuroblast,
Yes,
neuroblastoma.
yes. Raise your
Yes,
voice
sir.
again.
Yes, sir.
Tell
Yes,
us.
sir, neuroblastoma.
Yes.
Yes,
My
sir.
colleague,
Neuroblastoma can be.
when you see a posterior mediastinal mass in neonate or in very young child, both neuroblastoma in the top. Okay? In my opinion, if you didn't see even calcification, because why? This is the sympathetic chain. In neonate or in young infant, okay, the neuroblastoma is the most common one below 2 years. What's your next step, doctor?
Sir, next will be I also want to check the adrenal and MIBG scan would be helpful to locate the entire
This is
region,
only chest.
other areas of.
This is only
Okay,
chest,
sir.
doctor. What is your diagnosis? What's your
Sir,
next
yes,
step?
sir.
Sorry, your next step.
Sir, MIBIC or SPECT can be available or in the same city I have to advise something else.
I don't know. Tell me. In neuroblastoma,
Okay.
what is the next step?
Yes. Sir, bone mats, we can also have to check bone mats because they have very high.
Okay, doctor, but we didn't confirm.
Yes.
Doctor, there are a confirmatory test or investigation for neuroblastoma, very specific.
Yes, sir. Sir, VMA levels in vinyl mandelic acid in catecholamines in
Okay.
urinary sample.
Okay, oh, no problem. Correct. But in all neuroendocrine, secretory neurogenic
Yes, sir.
tumors or neuroendocrine tumors, we do a specific examination.
MIBG. Yes, sir. MIBG examination. Yes.
This is MIBG. What happened here?
Okay, sir. So these are the dynamic images from MIBG scan.
Not
Here
dynamic.
you can appreciate.
See, not dynamic. Why?
Okay,
24
okay.
hour. 24. This is very delayed. Very
Okay.
delayed. Tell me.
Okay. So there is an increased uptake, which is predominantly identified at the same
Increase.
position.
See, not increase
Yes, sir.
uptake. Because this is abnormal
It's
uptake.
persistent uptake. Yes, sir. Yes, sir.
Okay? Uptake. There are uptake of the tracer in here in the posterior mediastinum.
In the posterior mediastinum, yes, sir.
So this confirm neuroblastoma or not?
Yes, sir. It's confirmed.
Okay. What is the type of this neuroblastoma? We have two type, either adrenal or extra
Okay, extra adrenal.
extra adrenal. So this is
Yes, sir.
extra
Extra
adrenal.
adrenal.
Originate from the sympathetic chain in the almost in the paravertebral region. Doctor, do you think we may need a conventional bone scan? Yes or no?
Yes, sir. Because they have high like bone mats are very common in related to
Yes,
neuroblastoma.
but we can detect bone myths by this one, doctor. This is MIBG can detect
Yes, sir.
the bone myths. Why we need the MIBG? Sorry, besides the MIBG, we may need bone scan. Why?
Yes, sir. Sir, yes, you also told us that 26 to 30% will not release the MIBG or not detect MIBG. So
Excellent.
MDT bone
Excellent.
scan should
Because
be. So you all
yes,
previous class.
yes, because one third of the cases may not uptake the MIBG. Okay, and the neuroblastoma is very common to metastasize to the bone. So you can detect at least the metastasis at the bone by the osteoblastic reaction at the bone. Thank you, doctor, so much. It was extra adrenal neuroblastoma. Keep in mind,
Thanks.
home message my colleagues, any posterior mediastinal mass in young age, you will think about neurogenic tumor. Which neurogenic tumor? Which one? Neuroblastoma. Okay? The examiner may bring this one specifically. He wanted to listen from you. Differential diagnosis containing a neuroblastoma. Thank you, doctor, so much. Next candidate. Next candidate.
Hi, Dr. Rami.
Hi.
Yes, I'm with you.
Welcome. 45-year-old female patient. She has been diagnosed with hypertension.
Okay, this is ultrasound for a 45 years old female patient. I can see that there is a solid mass, hyperechoic or heterogeneous mass seen below the liver in the I think this is suprarenal region.
Yes.
It shows central vascularity.
Yes.
Okay, so this is I'm suspecting this is suprarenal solid mass.
Yes.
With vascularity. I'm suspecting this might be in patient with newly diagnosed hypertension. This might be pheochromocytoma.
Brilliant. What's your next step?
Pheochromocytoma. We can do CT or nuclear.
What is exactly the next?
The nuclear scan.
CC.
The tracer for.
It may be RCC. We don't know.
Yeah, so we can do CT first to confirm that this is a suprarenal.
Okay. This is
MRI. Okay.
Yeah. See, look.
Okay, this is there is a heterogeneous. This is a T1 fat sat. This is coronal T1. And I can see there is a heterogeneous area. Sorry, this is T2. I can see this is heterogeneous lesion seen with areas with cystic areas, and there is area of fluid level.
Okay. What do you think? Tell me. This is renal or suprarenal? This is the right one. This is the left kidney. Look. Renal or suprarenal?
Suprarenal and compressing the kidney. Yes, this is suprarenal.
What is your next step?
Suprarenal. Nuclear scan.
Okay, which nuclear study?
Octreotide.
Okay, octreotide. What else? For neuro,
MIBG as well.
For neuroendocrinal or secreting neurogenic tumors, we do either octreotide
MIBG
or MIBG. There are, by the way, my colleagues, there are some pharmaceutical significance in which they use either the MIBG or octreotide, but I think this is too much dilemma for us. Tell me what happened here. Look at this one. By the way, this is anterior, this is posterior.
This is anterior posterior. Okay. I can see there is uptake seen in this in the liver, and more uptake seen in the left suprarenal region.
So, what's your diagnosis?
This is confirmed that this is a neuroendocrine tumor, likely pheochromocytoma, according to the clinical history of the patient.
Excellent.
I will convey my finding to the referral clinician for clinical correlation and lab correlation for check the catecholamines and the vinyl mandelic acid, I think, in the urine.
You skipped from my question. Excellent. I was about to ask you about this mandelic acid. Okay, thank you.
Yeah.
But which test you are requesting to detect vinyl mandelic acid? Blood.
Urine.
Excellent. So you tell the examiner, you should tell the examiner, we must check the levels of vinyl mandelic acid in the urine.
In the
Brilliant,
urine.
doctor. Brilliant.
Thank you, doctor. Thank you.
Welcome. Next one, my colleagues, it was a case of pheochromocytoma. Pheochromocytoma, it causes a bout of hypertension and the sweating. It has a very characteristic clinical picture. We can detect any neuroendocrine or neuronal secreting tumor by either octreotide scan or MIBG. Okay? Thank you, doctor, so much. Take care, my colleague. In MRI, the pheochromocytoma gives something called light bulb sign. But here, due to the cystic necrosis, see, this is T2. Cystic necrosis. This is fluid level. If there are no cystic necrosis, you almost see the pheochromocytoma is bright. Well, bright T2. This is the light bulb sign. Thank you, doctor, so much. Next candidate.
Thank you, doctor.
Welcome.
Assalamualaikum.
Good salam.
Yes, sir. I'm candidate 8. Good evening.
Welcome.
Mm.
90-year-old male patient presented with diarrhea and vomiting. Now increasing abdominal distension. Look here.
Mm.
What happened?
Look
here. What happened?
There is a in this CT abdomen. There is a well-defined mass at the right
Yes.
right hemi-abdomen. Right.
Yes. Which part of the right hemi-abdomen? Upper or lower quadrant?
Lower quadrant. Sorry, lower
What is the
quadrant.
name? Yeah. What is the name of the lower quadrant?
Right iliac fossa.
Excellent.
Right.
Okay. What happened to this mass? Yeah, describe.
I think it's carcinoid.
Okay. But before describe something, the mass is enhancing or not?
Sorry?
Enhancing mass or not?
The mass appears to be homogeneously, I think homogeneously enhanced.
Okay. What is the surrounding this one? 1, 2.
With a surrounding
Yes.
nodes, enlarged lymph nodes,
Okay.
mesenteric lymph nodes.
Excellent. What about this limbs? Look. This. What is the name of the sign?
Mesenteric fat streakiness.
What?
Is it the fat streakiness, mesenteric fat streakiness? No.
The tethering, so speculation, okay, or desmoplastic reaction, okay. So what's your differential?
I think it's a carcinoid.
Excellent.
Carcinoid.
What's your next step?
And the next step, I would like to do a nuclear scan of.
No.
Sorry.
No, before nuclear scan, what's your next step? To look here.
Oh, okay.
Is there are any meds or not?
Sorry, sir. The liver.
Are meds or not?
Oh, meds. No focal lesion in the visualized liver.
So this is carcinoid tumor or carcinoid syndrome?
I think carcinoid tumor.
Excellent. Because carcinoid syndrome, we diagnose a carcinoid syndrome when there are hepatic mets. Okay. What is your next step?
I would like to do a nuclear scan, FDG as well as the gallium.
No, not FDG.
Gallium.
Yeah. See, I inform you just in the last case. This is neurogenic secreting tumor or not? The carcinoid. Why the patient have diarrhea? Why? because they are secreting something. For all secreting is neuroendocrine secreting tumors, we do
Okay.
octerio
Octerotype.
octerotype or octerio scan.
Octerotype.
Okay,
Okay.
this is octerotype scan. What happened?
There is increased uptake
Not
at the.
increase, my colleague, not increase. This is abnormal. This is
Sorry, there is.
abnormal uptake. What, see, what mean by increase? Because you are the second candidate that said that. Increase
Oh,
means that there are
sorry.
uptake here, and just this one only increased relatively in other organs. No, this is
No.
abnormal high uptake.
Oh, okay.
Yeah.
Yeah. So there's abnormal uptake at the
Excellent.
mass in the right iliac fossa.
So what's your diagnosis?
Is a carcinoid.
Okay.
Tumor.
Carcinoid. What is your next step, or what is your management?
In, alert this to the primary team to.
Yes. What
So,
will they do? Maybe resect the tumor. Okay.
okay.
Thank you, doctor, so much. My colleague take care. Sometimes this mass, welcome. This mass may occlude or invade the superior mesenteric, this vessel. I think during the follow both superior mesenteric branches, see what happened here. I think there are abutted or insinuated inside the mass.
Okay.
So
Okay.
try to pick up any ischemic changes. I show you before in the GIT sessions, one carcinoid tumor causing ischemia. I think here no obvious ischemia. Okay.
Okay.
But I wanted to tell you something. Sometimes the tumor, see my colleague, this is the tumor itself, the duodenum. Okay, the tumor itself. We just يعني pick up. This is the extension in the mesentery, but this is
Okay.
the origin here.
Okay.
Thank you, doctor, so much, because carcinoid tumor originate from ileum or appendix. Where is the appendix here? Or the appendix. Okay, the appendix here. How to detect the appendix? This is a terminal ileum. Follow it. By the way, this is appendix. This one. Follow
Okay.
it. Follow. Okay. So the ileocecal junction. You must start from here, posterior. Okay. This is the appendix.
Okay.
Follow. You see my colleague. This one. It is normal. Thank you, doctor, so much. Next.
Thank you.
Next candidate.
Assalamu alaikum.
Wassalam. Doctor, this 65-year-old male patient referred with abdominal pain.
These are axial sections from contrasting on CT abdomen at the level of bilateral kidneys. And there is a round hyperdense lesion noted in left lobe of liver. It could represent a simple.
Yes. What else?
There is a well-defined round lesion noted at the in relation to the tail of pancreas.
No. Look here. Here. What happened here?
This is a soft tissue area with internal calcification noted in relation to the wall of the small bowel.
Yes.
With associated with the thickening of its wall and luminal narrowing.
Yes.
Mild associated fat sending is appreciated. However, I could not see any teething or desmoplastic reaction. I would like to review the rest of the images. No enlarged lymphadenopathy seen, no intraperitoneal free air or free fluid noted.
Yes.
This eccentric
Yes.
and this eccentric show thickening can be small bowel lesion.
Yes. Give me differential diagnosis. Small
Uh,
small bowel lesion with calcification. Okay. What
it can be GIST, leiomyoma,
what else?
or it can be carcinoid.
What's your next step?
Next, I will do the nucleus and octreotide study.
Look here.
This is the PET study. In which there is bilateral symmetrical renal uptake. There is an area of uptake noted in the area of the small bowel.
What else? Do you detect
Along with
anything else?
in the also area of uptake in the liver noted.
What's your final diagnosis?
So it's most likely carcinoid syndrome.
Excellent. What you are worried about now?
I'm worried about the other disseminated mets in the liver as and carcinoid syndrome present with diarrhea, flushing, weight loss.
Yes. Yes. And what else? Now the tumor is in the liver, so it bypass its secretion will not destroyed by the liver, so it bypass the liver, bypass. So it can do some complication. What you are worried about?
Sorry, sir, I couldn't remember.
Yes, see, you are in the correct pathway. It is a carcinoid syndrome. Okay, it may cause some flushing, some diarrhea, and what else? Because if the tumor only here down in the ileum, so when it secrete anything, it is drained by portal veins. It go to the liver and it is destroyed. But now it
Sir, right side heart failure?
yes,
Right side heart.
yes, excellent. Because it may affect the right side of the heart. Okay, tricuspid arch, tricuspid valve. Okay, so it is a case of carcinoid syndrome, not just carcinoid tumor. So we are very worried about the right side of the heart. This patient need to be referred to which committee?
Refer to medicine.
What?
Sir, refer to surgery.
No,
Medicine and surgery.
GIT
MDT.
oncology. GIT oncology.
GIT.
And he may need a cardiac consultation if he has any symptoms. Thank you, doctor, so much. It was a case of carcinoid syndrome.
Okay, thank you, sir.
By the way, what's the name of this technique or this examination?
Octreotide study.
Okay. This is octreotide study scintigraphy. This is the tracer. Okay, you can do like this. This is a static octreotide. You can fuse the image in with a normal CT or with conventional CT. Okay, but when you fuse like this for anatomical localization, what is the name of this fusion? Look here, doctor. SPECT.
SPECT.
Okay, SPECT. SPECT CT. Okay, my doctor. Thank you, doctor, so much. Next candidate.
Yes, sir. Assalamualaikum.
Alaikum salam, welcome. 60
Okay.
60-year-old patient with fatigue.
Okay. So I'm presented with a spot image from nuclear scintigraphy of thyroid gland, likely technetium 99M. Here I can see the marker in the suprasternal notch and also at the level of chin maybe. I can see that there is minimal uptake in the region of the normal bilateral lobes of the thyroid gland. I can see that there is a rounded, well-defined area of marked uptake seen in the left lobe of the thyroid gland. Um, it could be hot nodule on of the thyroid gland. Other differential could be of any thyroid adenoma.
Are you sure
However, I will.
Are you sure this is
Sorry.
hot nodule?
Yes, it could be adenoma or hot
Yeah,
nodule because it's
see.
yes.
Either adenoma or nodule, but it is uptake. It has uptake, so it is hot.
Yes.
How to confirm this is sure hot nodule? Beside its uptake, what else?
From the thyroid gland functions.
No, from this isotopic scan.
Because there is no uptake in rest of the visualized area of the thyroid gland.
Thank you. Very easy. Look at the background. It should be here, the left lobe,
Yes,
right lobe at least. No right lobe.
normal.
No.
Mhm.
Why? Because why? Explain why.
Because
Why the absence of background thyroid uptake?
Because all of the tracer uptake has been accumulated in this area of nodule.
No. What else?
No.
Yeah, by the way, you are correct, but this is not the ideal answer.
Okay.
I will help you. This is very active nodule or not?
Yes.
What it is
Hyperactive.
secreting? Yes. What is the secretion here? T3 and T?
4.
Okay. They go up to the pituitary hypothalamic axis. What
Yes.
is the feedback? Negative.
Feedback is to
Mm.
yes, suppress the rest thyroid gland
Excellent.
secretion from the normal
Suppress
thyroid gland.
TSH. Okay. No enough TSH. Even no TSH. So this thyroid will not work. This nodule may be autonomously hot nodule, toxic, autonomously, not controlled or related to the TSH. So it work with its own self alone. But rest of thyroid need an order from TSH. Thank you, doctor, so much. By the way, my colleague, this is the suprasternal marker. This is the chin marker. Okay? This is a chin. Why? Look here. This is the mandible, by the way. Here. Here. This is the chin. So this is the lower neck. If this marker here and you have uptake here, here above the level of the mandible, so this is lingual thyroid. Again, this is suprasternal. This is chin. What mean by chin? This is symphysis menti. This is left mandible. This is right mandible. So this is the normal. Any other site are abnormal. At least you can find if you find here uptake of the technetium. This is lingual thyroid. You may find here even ectopic retrosternal thyroid. Suppose, yeah. Suppose it is very rare, by the way. But I'm talking how to localize the thyroid within the technetium pertechnetate. Don't confuse with the markers. The marker are very sharp and round. And look, both of them are similar in size. Okay? Very important. If you go to the Viva and in front of the examiner you confused with one marker, يعني 100% he will demarcate you markedly. Why? This is basics. Thank you, doctor, so much.